Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Boehringer Ingelheim Pharmaceuticals, Inc.
Hi, everyone. Thank you for joining this Cardio-Kidney-Metabolic collective in which we're going to discuss piecing together multidisciplinary and patient insights to optimize care. My name is Jennifer Green. I'm an endocrinologist at Duke University. And with me today is Dr. Harriet Van Spal, who is from McMaster University in Hamilton, Canada. So we're going to start today's program with review of a brief patient video, and then we'll regroup to discuss his case and how we might optimize care for patients like you'll hear from moving forward.
Hello, my name is Patrick G, and I certainly want to share my story of living with type 2 diabetes and chronic kidney disease. My journey began in 2003 when I was working then for the Virginia Department of Corrections. I was working as an institutional training officer and a corrections captain. I had been working very long hours, and I was feeling really sluggish one day. And I went to the nurse's station to give her my symptoms. And at that particular time, she asked me, had I ever had a glucose check? And I didn't know what she was talking about. So when she pricked my finger, she looked at the results, walked off. A few minutes later, she came back with another nurse and asked me to surrender my keys. When I asked her why, she told me that my glucose level was at 748. And if I did not surrender my keys, then being on state property, she was going to call the Virginia State Police Department and have me arrested for driving under the influence. So I surrendered my keys. I had an officer to take me to the nearest emergency room, and this is where they took my A1C and found out that my A1C at that time was 11.7. So the emergency room physician told me that I had type 2 diabetes and recommended me to an endocrinologist. My endocrinologist had treated me for 10 years from 2003 to 2013. And the only thing that she really did was to put me on metformin and give me 2 forms of insulin. 10 years later, April 2013, I go to my endocrinologist for just a routine checkup, and everything looked good. She said, "Hey, Patrick, I see you in 3 months." But as I walked out to the parking lot and I'm getting ready to get into my vehicle, my endocrinologist comes running out of her office. And she was like, Patrick, look, I forgot to tell you that you're at end-stage renal disease 3B and that you currently have between 30 to 35% kidney function. At that particular time, I did not know what she was talking about. At no time in the 10 years that she was treating me did I know that diabetes was the #1 leading cause of kidney disease. So I'm standing there stunned. And she said, Patrick, I'm going to refer you to a nephrologist. A couple of weeks later, I go to the nephrologist. The nephrologist was like, Patrick, you're going to eventually end up doing dialysis. So what we're going to do is to help slow down the progression of your dialysis by having you to abstain from nuts, dairy products, and chocolate. But during this particular time, I noticed I was picking up weight, and my urine output was lesser and lesser. Started dealing with a whole lot of mental health and emotional issues. And then we got up to November of 2013, and I go into my physician's office, talking to my nephrologist and saying, hey, doc, I can't sleep. I could barely talk. I was hyperventilating. my wife really had to speak for me. And she asked the doctor, when was I going to do dialysis? So it was at this time I opted to do peritoneal dialysis, and I had the surgery, waited 2 weeks later to recover. And on December the 1st, 2013 is when I actually started doing the very first exchange of peritoneal dialysis. I did this for about 3.5, 4 years, all the way up into April the 21st, 2017. And that's when I got my call for my kidney transplant. So thank you.
Well, I appreciate Patrick sharing his story with us. I would say my first impression is that, unfortunately, he seems to have had a number of heard about his medical conditions as a series of unpleasant medical surprises. And I think that what we're going to be talking about today is an increased focus on both screening, in particular for that of chronic kidney disease, and how we can work together as a community, which includes the patient, to ensure that we are outlining a treatment plan that can minimize the risk of individuals' progression to end-stage kidney disease and/or other complications. Harriet, did you have any thoughts about any other thoughts about the recording?
I empathized with Patrick's journey, and I felt that his case highlighted so many missed opportunities that we have every day in our clinical settings to educate patients about their diagnosis, but also the risk factors that could be modified to improve disease trajectory, to educate them about therapies that are evidence-based, to implement those therapies, and then to guide them about the complications that surface over a span of months and years, and discuss some of the strategies that are multi-pronged that we could embark on as a team to avert those complications. So in his case, diabetes is underpinned by metabolic risk factors that could have been addressed. He could have had therapies to improve the outcomes following his diagnosis of diabetes. And he could have had a frank discussion about the multi-organ complications that could ensue over a span of months and years, and the importance of screening for those complications, and then have therapies implemented to avoid those complications. So several contextual factors that we should anchor the rest of our brief time today in.
I completely agree. All right, I'm going to hand the next few slides over to you for presentation and discussion.
Sure. So Patrick's journey really brings us to this focus of today's discussion on cardiovascular kidney metabolic syndrome. This is nomenclature that was devised by the American Heart Association recently, and it nicely highlights how our patients with cardiovascular disease also live with kidney disease and metabolic syndrome. And so our approach as specialists should go beyond the organ-specific care that we have all been trained to deliver and really be comprehensive in its approach. All of these conditions are underpinned by shared risk factors that begin with adiposity, abnormal adiposity, that could be manifested as overweight or obesity. So patients with high weight and high BMI. Now we could have discussions about whether BMI is the best way to assess for adiposity, but BMI is broadly used, and we could certainly assess that in our patients. Also assess them for abdominal obesity that could be assessed with a weight measure, a waist measure. And then an alternative way of assessing adiposity and abnormal weight is through a waist height ratio that is slightly more advantageous in giving us a comprehensive picture of our patient's metabolic health. We can also measure labs to assess for diabetes or impaired glucose tolerance. But all of these factors culminate in a syndrome of hypertension, hypertriglyceridemia, and dyslipidemia, metabolic syndrome, kidney disease, and then type 2 diabetes. And of course, all of us know that type 2 diabetes is a marker of worse prognosis than people who don't have this condition, because it can progress to vascular, cardiac, kidney, liver, and other complications. These are manifested subclinically through subtleties that we could screen for in our clinical settings. But beyond these subtle findings on investigations, patients can manifest with significant clinical presentations such as stroke, heart failure, heart attacks, peripheral arterial disease, and dysrhythmias. And each of these have downstream complications that result in death. Now, our patients with heart disease, as I alluded to, also have many of these other complications that we just discussed. This is our analysis of a pragmatic clinical trial of 4,400 patients that I led. And we looked at the intersectionality of different disorders in these patients who were hospitalized for heart failure for the first time. They had come in and received their index diagnosis of heart failure. And we found that in our patient cohort that is depicted here by the big, large gray circle, close to 80% were living with hypertension for many years, in fact. Diabetes, more than 50%, close to 55% had type 2 diabetes. Close to 25% had established kidney disease that had already been diagnosed. Now, these patients had not been actively screened for kidney disease, so this is certainly an underestimation. We know that with active screening, close to 50% of our patients with heart failure actually have early stages of kidney disease. But these are patients that are missed because we don't actively screen for albuminuria, and we don't look for those early signs of reductions in eGFR. We found that after adjusting for other comorbidities, patients with kidney disease who had come in for their first diagnosis of heart failure were at a 55% greater likelihood of death than patients who did not have kidney disease at that time. So among patients with heart failure, kidney disease portends a worse prognosis. 81% of patients who had kidney disease were dead within 5 years, as compared to 62% of patients without kidney disease. So heart failure is certainly a high-risk condition. Most patients do not survive that 5-year period, but if they have kidney disease, they have a much higher risk of not surviving that 5-year period. So what is kidney disease? Chronic kidney disease is diagnosed with persistent, and by that I mean about a 3-month continuous period of a reduction in GFR to less than 60 mils per minute per 1.73 meters squared, or persistent albuminuria greater than 30 milligrams per millimole. And so this should be, I should say 30 milligrams per gram rather. So these are lab markers that could be screened for to ensure that you don't miss the opportunity of detecting kidney disease early enough to implement therapies to change the degree of kidney disease that will occur following the early diagnosis. This is a busy panel of a lot of different colors, and I want to draw your attention to each of these boxes. So there's 6 boxes here on your right. Each of them measure some endpoint. The first one is all-cause mortality. The next one to the right is myocardial infarction. The middle rows are cardiovascular death and stroke to the right. The bottom ones are kidney failure requiring dialysis or kidney replacement. And the last one is heart failure. The plots, the horizontal axes here show you degrees of albuminuria. So these are urine albumin to creatinine ratios, and they show you from the left aspect a UACR less than 10 to greater than 1,000 milligrams per gram within each box. So as you move towards the right within each box, your albuminuria is increasing. The left or vertical panels show you the eGFR thresholds in these patients from normal at the top to going down the rows severely abnormal. So you're going from greater than 100 to less than 15 as you go down each of the boxes. And what you notice is as you move to the right and you move down within the boxes, your colors move from green to red. And green is neutral risk, where your risk of the endpoint, and we're talking about mortality, MI or heart attacks, cardiovascular death, stroke, kidney failure, end-stage kidney failure or heart failure, increases substantially as the albuminuria increases and as the estimated GFR decreases. And in fact, I could have plotted 12 boxes because other cardiovascular endpoints, such as peripheral arterial disease, atrial fibrillation, and other cardiovascular events all increase as the severity of albuminuria increases or as the eGFR decreases. So not only do these tests screen for kidney disease, but they're actually markers of risk that could be used strategically to deploy therapies, not just to change the trajectory of kidney disease, but as we now know from several trials, to change the trajectory of cardiovascular disease that we know takes most of our patients with kidney failure. Most patients with kidney disease, in fact, die of cardiovascular disease. And that, I think, brings me to the next slide, which is yours, Dr. Green. So I invite you to weigh in on some of your thoughts around the content that I presented, whether you use these screening tools and whether you use them as a marker of diagnosis, prognosis, and their thresholds to implement therapies.
Yes, so absolutely I do. And in my slides, I'm going to talk a little bit about why I do as an endocrinologist. And, I would like to make sure that we are revisiting Patrick's experience. Now, we don't know how long ago Patrick was diagnosed with these various conditions. And it's true that at one point, we had a few interventions to offer people who had been diagnosed with kidney disease to alter their outcomes in meaningful ways. But this is a whole new world, and we need to, we're not talking so much about treatment in this presentation, but you first have to start with awareness and understanding how, as you've outlined, we need to screen for kidney disease, particularly in people with diabetes, because there are so many opportunities to make a difference in these outcomes. And I'm going to give one example. I show this slide very often, and this is a summary of an analysis that was done by a group at the George Institute in Australia. And what they were interested in was determining what the costs and benefits might be of treating everyone in Australia with type 2 diabetes and either chronic kidney disease and or cardiovascular disease with an SGLT2 inhibitor for 10 years. And obviously that requires an upfront investment that is substantial. However, when they looked at the benefits to treating everyone who was eligible for such treatment for the 10 years, they found that for each dollar invested, there was $5 in ultimate cost savings. And that was due to about over 4,000 people having fewer events of an acute kidney injury, almost 9,000 fewer individuals progressing to end-stage kidney disease, over 4,000 fewer myocardial infarctions, and about 7,500 fewer deaths. So the impact of these interventions is not trivial, but we really should be diagnosing and treating people early, because then the intervention is likely to be the most cost efficient over time. Now, these are the KDIGO guidelines for screening and diagnosis, and some of this has already been covered by Dr. Van Spal. So again, we need to screen patients for chronic kidney disease with both the eGFR and the spot urine albumin to creatinine ratio. And these are not new recommendations for people with type 2 diabetes or type 1 diabetes for that matter. These are recommendations that have been in place for decades. So these are not new, expensive tests to conduct. These are what we should have been doing all along. And remember that for people with type 2 diabetes, their screening for CKD needs to start immediately. And that is because close to 10% of people with type 2 diabetes will already have what we consider to be diabetes-related complications at the time of their diabetes diagnosis. For people with type 1 diabetes, because that is a bit more of an acute onset of diabetes, and they haven't been exposed to hyperglycemia for years before the type 1 diagnosis is made, you could give them 5 years before you start screening for diabetes-related complications. But for people with type 2 diabetes, start screening for kidney disease and other diabetes-related complications immediately. And don't forget that many people with type 2 diabetes have many other independent risk factors for CKD, like hypertension and excess weight as well. So we don't make a diagnosis of CKD if one lab is abnormal one time. As has already been mentioned, this abnormality needs to be persistent for at least 3 months. So the reduction in eGFR below 60 or the UACR elevation to above 30 milligrams per gram for at least 3 months. But really, when you think about it, particularly that abnormality in UACR is so modest and happens so early in the course of diabetes that we probably have many patients in our own clinics who have CKD, but we just don't know it because that UACR testing has not been done. Microalbuminuria is, of course, a marker of CKD risk or the presence of CKD, but albuminuria is also associated with an increased risk of cardiovascular disease and probably is an indication of more widespread vascular damage. And particularly in people with CKD related to diabetes and or many other conditions, abnormalities in UACR are detectable often for quite an extended period of time before the eGFR drops to below 60. So don't forget to include that. Now, screening, of course, is just the first step in the CKD diagnosis and management pathway. The UACR testing, unfortunately, these are data from Dr. Kathy Tuttle, who is in Washington State, and she has access to data across a wide variety of settings. She looked, this was several years ago in the United States, looked across these care settings to see how often people were being fully screened for CKD if they had diabetes, and how often they were treated with really the fundamentals of therapies for chronic kidney disease. And what she found is that across these settings, only between 10 to 40% of people with diabetes had their UACR checked annually. So again, tremendous opportunity here to detect many people with this important complication. Now, of course, people with diabetes and CKD, or anyone with CKD, is supposed to be treated with their max tolerated dose of an ACE or ARB. And in this, again, in this review of data, only between 25 and 40% of such people were being treated with these therapies that have been recommended again for extended periods of time and that are not expensive or difficult to access. Because the SGLT2 inhibitors were somewhat more recently recommended, we would expect their utilization rate in this population to be lower, but it was so incredibly low, 13%. Really, the vast majority of people with these conditions are untreated. And at the time of this survey, finerenone, the non-steroidal MRA with indications for use in this population, was so new in its availability that almost no one was being treated with it. Now, my guess is that these numbers have continued to inch up over time, but still, it is likely that the majority of people with type 2 diabetes and chronic kidney disease are not treated with these conditions and are often not aware that they have the condition because they haven't been fully screened. And when we talk about treatment, unfortunately, the clinical inertia around treatment of chronic kidney disease or many other chronic conditions is not fully an access issue. That tends to be the explanation that is given when we ask about barriers to implementation of evidence-based therapies. This is one set of data from, for example, the VA healthcare system in the US, of which I am also a physician. And this survey looked across each of these little thin blue bars represents an individual VA location within the United States. And this survey looked at the proportion of people in each individual VA health system with type 2 diabetes and established atherosclerotic cardiovascular disease who were treated with an SGLT2 inhibitor or prescribed an SGLT2 inhibitor in 2020. And this was a full 5 years after these medications were made completely accessible to this patient population. And what you see is 5 years after these drugs were readily made available to this patient population, only 15% of eligible individuals across the board were prescribed an SGLT2 inhibitor. You can see there's a range from some VAs not prescribing the drugs really at all to up to maybe about a third of people receiving a prescription. I hope my VA is up towards that end, but I don't know. So it's certainly not explainable by problems with access. I mean, obviously that is a factor, and it is a greater factor in certain locations and patient populations than elsewhere. But there just appears to be inadequate implementation for many other reasons as well. Some of that may be due to the fact that we tend to, unfortunately, toss responsibility for certain risk reduction strategies around like a hot potato from one specialty to the next. And, you know, sometimes what primary care docs and endocrinologists and cardiologists and nephrologists think of as being their responsibility does not overlap as much as it should, particularly in the United States, where most nephrologists are focused on the care of patients with very advanced kidney disease. But when we practice in such a fashion, unfortunately, the care of at-risk individuals tends to fall through the cracks. So we really need to try to bring these shared areas of responsibility closer together. And even if we're not comfortable necessarily prescribing a certain indicated drug, we need to communicate very closely with the individual in whose discipline that, I suppose, falls most squarely. In this sort of vision of the future, you'll notice I don't even have the nephrologists here at all. I'd love to keep my patients from needing them if we diagnose early enough and intervene effectively, so that maybe their services are needed less often. So we've used up a lot of our time. Just getting back to Patrick's case, I think it's really clear that it would have been helpful to him personally and with respect to his clinical outcomes for him to be diagnosed with not just kidney disease, but also diabetes at an earlier stage. And of course, there are very standard guidelines in place for screening for both of those conditions, but we're probably not implementing them fully. And communication among not just the primary care doctor, but the specialist that a person might be visiting or need to visit as well is really essential. But thank you very much to everyone for joining the program. And thank you, Harriet, for joining me as well.
Thank you, Dr. Green. Thank you, everyone, for joining us. Let's go out there and be proactive, screen for kidney disease among our high-risk patients. And also keep in mind that the same therapies that reduce cardiovascular risk reduce kidney risk. Thank you all.